management of patients with in-stent restenosis, imaging is crucial to both understanding the mechanism of stent failure and optimizing your procedure for good clinical outcomes. So without imaging, you'll just have a patient whose stent has failed. You don't know if that is because the stent's underexpanded, you don't know if there's stent malposition, or you don't know the mechanism of the new disease. Is it neointimal hyperplasia, or are we talking about neoatherosclerosis with or without calcium? Imaging is really your only tool in differentiating between those different mechanisms of stent failure and different patterns of disease. And the importance of that is that it really influences how you treat it. Do you go after various methods of expanding the stent further? Do you use cutting balloons to get into that neointimal hyperplasia? And once you've used your imaging and to determine how to treat the disease, and you've adequately treated the disease, before you go forward with therapy with drug-coated balloons, it's really important that you repeat your imaging to ensure that you've got a great procedural outcome, and you've got your stent result, or you've got your treatment of your in-stent stenosis to be as good as can be. Once you've treated the disease in the way that you think need to be treated, repeat imaging is also crucial. We know that when you repeat IVUS, you can assess to see how well you've expanded your stent. You can make sure that you don't have any distal edge complications, and at that point, you know from a vessel preparation procedure, your procedure is complete. Then you can go forward and use your drug-coated balloon as the final step in the management of that patient. When we're talking about the management of patients with in-stent restenosis, angiographically, a lot of these diseases can appear the same. And I can think about two patients that I treated recently that both presented in similar fashions with NSTEMIs, and when we did their angiogram, they both had left main intercircumflex stents that had restenosed. Now, the mechanism of those stent failures were wildly different between the two. In one case, there was very aggressive neointimal hyperplasia, which was picked up on the IVUS, and that was treated with cutting balloons to ensure good lesion preparation, followed by drug-coated balloon to hopefully reduce the risk of target lesion failure. In the second patient, although angiographically it looked very similar, on intravascular imaging we demonstrated that the stent was actually grossly unexpanded. And so that required a different approach. We needed to use aggressive dilation with non-compliant balloons to high pressure to expand that stent adequately, and then use IVUS again to check that we had a good result with our procedure before, again, using a drug-coated balloon to try and improve our long-term outcomes. When treating patients with in-stent restenosis, intravascular imaging is really key to understanding the mechanism of why the stent has failed, and also assessing your result of your procedure prior to using the drug-coated balloon. And both of these things are really important to improve the long-term clinical outcome for your patient. With the use of intravascular imaging, you can understand the mechanism of stent failure. Is it a poorly expanded stent? Is it a stent that has poor vessel apposition? Or is the mechanism of disease either neointimal hyperplasia or neoatherosclerosis? Imaging is really crucial in trying to understand which of these mechanisms are at play and determining how you're going to treat it. Once you've treated it, imaging is subsequently important to ensure that you've adequately prepared your vessel prior to that final step of applying the drug-coated balloon. The use of intravascular imaging is crucial when managing patients with in-stent restenosis. We know both from European and US guidelines that it's recommended with a 2A recommendation, and it is really important to try and both understand mechanism of stent failure and assess the adequacy of your result when doing these procedures. In terms of technological advancements that have happened recently, we now have much greater definition with IVUS that allows us to get really great high definitive images both of native vessels and of previously stented vessels to understand mechanisms of stent failure and to also assess the results that we can achieve with intervention. In terms of specific technological advances, the new AVVIGO system allows for automated lesion assessment, which really works with kind of works with creating greater efficiency with clinical workflow, where you can look at lesion characteristics and vessel diameters in a very automated, quick way from the cath lab table. Imaging is really important in the management of in-stent restenosis. We have retrospective studies that have shown that the use of imaging whilst treating these patients with in-stent restenosis can improve all of your clinical outcomes, from MACE, from cardiac death, from target vessel revascularization, and from target vessel myocardial infarction. This goes in hand with kind of more contemporary clinical studies looking even outside of the realm of in-stent restenosis, where intravascular imaging has been shown time and time again to improve clinical outcomes, specifically with the use of IVUS in these patients. Vessel preparation and the management of in-stent restenosis is critical to improving the long-term outcomes from that procedure. Vessel preparation, again, is dependent on what you see on your imaging, and you need to ensure that the previous stent is well expanded and well opposed, and you also need to make sure that you've treated that new disease, be it neointimal hyperplasia or neoatherosclerosis, adequately. Using imaging, you can decide whether you need to use a cutting balloon or high-pressure non-compliant balloons or other various methods of calcium modification to try and optimize your result. Vessel preparation is really important when we're looking at the efficacy and safety of the drug-coated balloon procedure. We know that unless we've got good expansion of the previously placed stent and we have no significant residual stenosis, that we will not get as good an outcome compared to then when we do. So both intravascular imaging and kind of judicious use of all the tools in the cath lab, being cutting balloons or high pressure non-compliant balloons, is really important to prep the vessel appropriately prior to using your drug-coated balloon. Vessel prep is really important when improving outcomes for these patients that are treated with in-stent restenosis. I can remember a patient who I recently treated who had stent failure only 6 months after his index procedure. Now, at that point, we did intravascular imaging and we demonstrated that the stent had significant malapposition to the native vessel. And at that point, we expanded the stent with non-compliant balloons. As a result of the malapposition, there was subsequent neointimal hyperplasia, and we used the cutting balloon to kind of improve those. We checked that result with intravascular imaging prior to using the drug-coated balloon to try and improve the long-term outcomes. We know that when we inadequately prepare vessels prior to using the drug-coated balloon, we are setting ourselves up for failure. If we have poor expansion of the previous stent, if we have a significant residual stenosis, if there's evidence of distal edge complications, or if there's evidence of poor stent expansion, our outcomes are worse in these patients than in those that haven't got it. So I think it's really important to take time to image the vessel, to prepare the vessel adequately, and then to re-image to check that your result is adequate prior to using the drug-coated balloon. Compared to procedures where you're going to be putting in a stent when you're treating de novo disease, vessel preparation is even more important when treating in-stent restenosis with the drug-coated balloon. Obviously, when you're treating de novo disease, you're ensuring that you've got adequate lesion preparation, you're using imaging ideally to improve your outcomes, but your final step is to deploy a stent which provides a rigid scaffold to try and hope to keep the vessel open and reduce long-term complications. The idea of treating in-stent restenosis is really to avoid that second layer of stent. We're treating it with the final step of a drug-coated balloon, which, although applies drug to the vessel, doesn't give you that rigid platform. It's not a step in the procedure where you're going to further prep the lesion. It is kind of a final polishing step to try and improve your long-term outcomes. And in that setting, I think that we need to be very judicious to ensure that these lesions are adequately prepared, well-expanded vessels prior to using the drug-coated balloon. In patients with in-stent restenosis, one of the most common mechanisms of stent failure is neointimal hyperplasia. This is very different from de novo atherosclerosis and requires slightly different treatment options. I found in my clinical practice that using a cutting balloon to try and get into that fibrotic tissue is a very good way to allow those lesions to fully expand and to adequately prepare those lesions. Also, conceptually, prior to using a drug-coated balloon, I think the use of a cutting balloon probably increases your amount of drug transfer onto the lesion.